Good evening, everyone. Welcome to Increasing Profitability with the Oculus Keratograph 5M by Dr. Jamie Kuzner. My name is Carver. I'm a clinical application specialist here at Oculus. And before we begin, I have a few things to go over. We'll be answering questions at the end of Dr. Kuzner's presentation. You can submit questions at any time by using the text box on your GoToWebinar screen. The earlier you ask questions, the more likely your question will get answered. Second, legally, there are some questions we cannot answer regarding billing and reimbursement. For example, we cannot tell you how much to charge a patient for a specific service out of pocket. Our speaker tonight is Dr. Jamie Kuzner, a very accomplished OD who practices at Birmingham Vision in Michigan. She received her doctorate of optometry degree from Michelin College of Optometry at Ferris State University, and after optometry school, Dr. Kuzner completed a corneal disease and contact lens residency at Indiana University. She is a fellow of the American Academy of Optometry, as well as a fellow of the Scleral Lens Education Society. And now, Dr. Kuzner.
Thanks so much, and thanks to all of you for joining me this evening. I know everyone's super busy and it's the middle of the work week, so I just really appreciate everyone tuning in to join me today for the broadcast. So I'm here to talk to you about the Keratograph, and I've been using an Oculus Keratograph for about 6 years now. And the most interesting thing in this webinar is I'm not going to talk to you about topography. So I'm going to talk to you about a great topographer, but I'm going to show you some other ways that you can use it more specifically with your dry eye practice. So everybody knows, dry eye is a huge growing industry. So I'm just going to run down what sort of topics we're going to go over tonight. So one, just talking about dry eye practice within your primary care practice. Next, we're going to talk about some tips for capturing the patients during your comprehensive exams and how exactly do you do that. Third, I'm going to talk about the importance of medical follow-ups, okay? So not only capturing them, but also bringing them back into your office for a second visit. After that, we're going to talk about how actually I use the Keratograph in my office for the dry eye analysis of my patients. After that, we're going to talk about the importance of meibography. And then at the end, I'm going to show you some cases that actually show how you can improve your compliance with your dry eye patients with the Keratograph as well. So jumping right into it with dry eye. So like I said, I've been using the Keratograph for about 6 years. I got a lot of experience with it when I was doing my corneal contact lens residency at Indiana. I knew it was a great tool. So when I joined the office that I'm at now, I was just in luck because their topographer had just recently broken, right? So they were in the market for something new, and I had recommended using the Keratograph because not only do you get a great topography for contact lens fittings, and all of that, but you also get a great tool to grow the dry eye practice, which they were looking to do. So one question I like all of you to think about is dry eye the new presbyopia? So just think about that for a second. I know that's sort of weird to bring up, but is dry eye something that's going to happen to all of us eventually? Is this one of those things that all of us are going to end up with 20, 30 years down the road? We all know that screen time is increasing, and we're seeing a lot of younger and younger patients experiencing symptoms. So I really think adding dry eyes, especially to your office, is really going to grow your practice and really attract a lot of patients to your office. So let's talk about patients coming in. So we know that on average, if it's just a regular comprehensive exam for your patients, a lot of times patients don't come back except for every maybe 2 to 2.5 years, or when they break or lose their glasses, right? Or they feel like their vision is changing. We know that contact lens patients will come back more frequently than that. However, if you have patients in your office more frequently for medical visits, say glaucoma or macular degeneration or dry eye, they're coming in more frequently. And I find that those patients tend to spend more money in the optical. So maybe they didn't buy glasses at their comprehensive exam, but you see them 6 weeks later, 3 months later, 6 months later, and they decide to update their glasses, or they see that new pair of sunglasses sitting there on the shelf. I'm seeing a lot of patients in your office spending money, right? Getting things that they need for their eyes. And they're more likely to come back for their annual exams. So think about it. If I saw someone for a 3-month visit for their dry eye or a 6-month visit, I can look back and say, hey, you're due for your annual exam where we're going to update your glasses in 6 months. Let's get that scheduled right away, versus not seeing them for over a year and having them remember with their busy lives to come back to see you. And also, happy patients is a happy office, right? So I'm finding that my dry eye patients are sending me so many of their friends and family members because I'm actually finding, the cause of their dry eye and treating it. So it's that word of mouth referral that's leading more patients to come back to your office. Also, it's a great way to market yourself to area eye doctors, ophthalmologists, optometrists, even like primary care doctors. Think about dermatologists. A lot of people don't want to manage these chronic dry eye patients. Sometimes I don't want to manage these dry eye patients, let's be honest. So they're difficult, especially a lot of ophthalmologists, right? They don't want to see these patients coming back that are just unhappy and with a chronic condition. So make that your specialty. Make it your office where they can just refer that patient to that's always miserable with their dry eye with no matter what drop you give them. And also, the way you really have to do that is to invest in diagnostic equipment and treatments in your office, okay? You're not going to grow a dry eye practice by just writing a prescription and sending them away for a year or giving them a new artificial tear. You really need to invest in your office with at least something like the Keratograph that's going to help you to diagnose your patients better. So the hardest part about dry eye that I find is getting your patients to realize that they have a problem, right? It's just like an addict, right? The step one is admitting that you have a problem. So realizing that they have a problem, but also getting them to invest in therapy. Unfortunately, dry eye is an extremely expensive disease. And I say it's a disease because I want patients to understand this is not something that's just going to go away overnight, okay? Unfortunately, there's a lot of out-of-pocket expenses for your patients. A lot of insurances don't cover a lot of the treatments that they need. So some of us might see that as a good thing or a bad thing, no matter how you want to look at it, but dry eye is expensive. So how do you convince your patients that the treatment modality that you're prescribing for them is worth it for them and is something that is going to help improve their quality of life? So the main thing you want to do is you definitely want to educate your patients before they get out of control. You don't want to wait until their eye is 3+ SPK and they're using drops every single hour. You want to get those patients when they're having contact lens discomfort or dropout. You want to get them when they just start using artificial tears, or maybe even when they're asymptomatic. And lastly, I want you to think about a picture is worth 1,000 words, but do you think a picture could be worth $1,000, right? So whenever I talk about dry eye to my patients, they don't really know what I'm talking about. If I say SPK or, issues with their cornea or your meibomian glands, they don't know what that is. If you can show them a picture of their cornea and the staining on their cornea, if you can show them a picture of their glands and the atrophy, they're more likely to invest in their treatment when they realize what actually is going on. So look at the pictures I'm showing you here. So these pictures are actually taken on in, quote unquote, asymptomatic patient that came in for their annual exams. So this is a great example of an initial capture, okay? A lot of times patients' symptoms and signs don't always match up. I'm sure we've seen patients with symptoms that are crazy, 10 out of 10, my eyes are so dry, I'm miserable, I can't function, and you don't see anything wrong with them, right? And how frustrating is that? And then you have the patients that are the opposite, where they have so many signs, so much staining, so much inflammation and redness, but they say, I don't have dry eye, I don't know what you're talking about, I don't have a problem, my eyes feel great. So one thing that we decided to do was actually just add additional screenings during their normal routine workup for their annual exams, okay? So what we started doing was adding the baseline lower lid scan, so which is the picture here. So these really only take a few seconds or maybe 30 seconds. It doesn't take very long. We have the Keratograph set up in a room where we're already doing blood pressure, we're already doing color vision, we're already doing eye care. It's just one more thing to do for your patients, okay? So doing these lower lid scans really helped us to find a lot of patients where, wow, I wouldn't have really thought that they had dry eye, but looking at their lower lids, there's definitely something going on there. Like, look at all that atrophy there. No wonder why they're having issues with their contacts and they're dropping out, right? Another great thing you can do is actually do an OSDI or a speed questionnaire. So just doing something simple that the patient can fill out while they're in the waiting room or beforehand really gets you an idea and gets them thinking about, do I actually have dry eye? And some people say their eyes are fine, but then you look at their questionnaire and it might speak differently, right? And also just taking a good patient history. So our technicians are really trained to know to ask patients, are you using artificial tears? How often are you using artificial tears? What all are you putting in your eyes? Do you have dryness at the end of the day? Asking all of those patients to all of those questions every single time that they're in the office, right? Because a lot of times they might not bring it up to you as the doctor. So it's really important that your technicians and your staff know to ask the right questions to your patients. And then obviously you want to also do your slit lamp examination as well. So doing fluorescein or lissamine green is often very telling just at the annual exam. So mention, I didn't talk about treating anything at the annual exam. So I'm not going to get on our soapbox and talk about how vision care plans don't reimburse us enough to treat dry eye and all that. I think we already know, right? So in my opinion, if I'm doing something more than just prescribing an occasional artificial tear or changing their contact lenses, I explain to the patient that this is an issue I'm concerned with, and I actually want to have you back for more testing. I don't just want to throw on another drop, right? Why don't you try Restasis or Xiidra or Cequa or whatever new is on the market? I'm not just going to throw them on a prescription and tell them, see me in a year. Let me know what you thought, or let me know if it gets worse. So I explain to them, I'm concerned with what I'm seeing. I'm concerned with your lower lid scans. I'm concerned with the staining on your cornea, or I'm concerned with some of the problems that you brought up to me. You're dropping out of your contact lenses at 6 o'clock, or you no longer can wear contact lenses. I say, I'm concerned for your eyes. So what we're going to do is I'm going to have you back and get a really good baseline to tell me what actually is the root of the problem. And I explain to them, I'm going to look at your tear film. I'm going to look at how much tears you're making. I'm going to look at the quality of your tears. And I'm also going to image your oil glands to see if there's a problem. And then that way I'll know exactly what I'm treating. And when I explain that to my patients, it makes complete sense. And a lot of times I say, well, why has no one ever offered this before? Or, that they're frustrated with previous doctors not offering that to them, right? So have the patient back. Usually you can bill anywhere between like a level 3 and a level 4 visit. You can also bill for external photos or mammography, whether that goes through their insurance or if it's private pay, that's an option. Okay, so you want to have your patient back. I don't have enough time during the exam to go over an entire treatment protocol for my patient for dry eye after a routine exam. So I have them back. That way I can spend more face-to-face time with them and they come back in the office and we get great baselines. So we talk about planting the seed for a 6-week follow-up. So I even say, I'm going to see you for your baseline visit. We'll determine what's going on. I'm going to write up a treatment plan for you. And then I'm going to have you back in 6 to 8 weeks. And I'm going to check in and see, are you doing better? And if not, we'll pivot and we'll try something different. And I think that's really reassuring to your patients. And it also plants to see that you're going to be coming in for a few times because this is a medical reason. Okay. So let's change gears a little bit. I'm going to talk more specifically about the dry eye reports that I do on the keratograph. Okay. So the main things that the keratograph is going to look at is the tear meniscus. So the tear height or the tear volume that you have. It's also going to do something called a non-invasive keratograph breakup time. So you can think of this like a nick butt, so tear breakup for your patients. It's going to look at a redness scale. It's also going to look at the lipid layer of their tear film. You're also going to do an OSDI score and actually input it into the system. You'll do mammography. And then the great part too is that there's a great customizable report that you can print out for your patients so that they can take something home and actually remember what you told them at their dry eye exam. So let's start out talking about the tear meniscus. So you can see in the image there, this is the first test that we always do for our patients. So all they're going to do is their chin is in the chin rest, and what the patient does is they look straight ahead, and the technician just takes a quick image. And all they're going to do is actually measure with the calipers what their tear volume is. So this is a great way to rule out if someone actually has aqueous deficient dry eye, or if they need something like punctal plugs or Restasis, or just more tear volume, right? Only about 20% of our patients are actually having a tear volume problem. A lot of time it's actually MGD or an oil production problem. So this is a great way, and also like a non-invasive Schirmer's. So I'm going to be honest, I don't do Schirmer's anymore, okay? It takes a long time. Your patients are uncomfortable just sitting in the chair. So this is a great way to get a good repeatable measurement without actually putting something in the eye with the tear on the actual natural state. The next test that you do is that non-invasive breakup time. So this is my biggest impact map that I can do. So what it does is the patient blinks a couple times and then they open their eye and they basically have a staring contest with the machine. Okay, so while they're staring and holding their eye open, it's going to start to highlight areas that break up. So just like if you're instilling fluorescein in the slit lamp and watching that and counting in your head, this is actually going to map it out for you. So it maps out when the tears first break. It also maps out the average tear breakup time, okay? This, I always show my patients as a video in the exam room. So I talk about, do you ever have fluctuating vision throughout the day, or you feel like you have to blink a lot to see clearly? Do you feel like your eyes are blurry? Do you feel like you're getting burning or wateriness? And a lot of times they're like, yeah, exactly. After about 3 seconds, I feel like everything gets blurry with my contacts or blurry with my glasses. And that doesn't make sense to me. So I show them the video and I say, just watch the video, okay? This is when you are having that staring contest. And I'm sure right about now, your eyes are getting pretty irritated and blurred and burning. And they say yes. So then I show them, this is actually mapping out areas where the tear is evaporating from your eye. And that is a great visual for them. And they say, wow, that makes complete sense. And for a patient like this, so I would say after about 5 seconds, the tears started evaporating from your eyes. And after about 10, most of them were gone. So the number I like to see is maybe 15 to 20 seconds. And when I put it into that perspective, they say, wow, my tears are really staying on about 1/3 of what someone should. So that really gets down to the root of the problem and shows them there is something going on, okay? The next map I like to show is the redness scale. So redness, and I always have to put a disclaimer on this with my patients, they are not used to seeing their eye close up. So a lot of times it looks redder than what they realize when they look in the mirror, okay? But this is a nice objective redness scale. So it's gonna grade your patient with limbal redness, as well as just all over conjunctival redness, bulbar, okay? And it's gonna grade it from 0 to 4. So I rarely will see someone at a 0 unless they've used Lumify, which is something that you should be asking your patients because a lot of times they're using Lumify every day to mask their dry eye symptoms of redness, okay? So you really wanna make sure they're not using Lumify or Visine or anything over the counter like that before they come in for the exam. But this is a great grading scale so you can show the progression of their dry eye, or hopefully as their dry eye is improving, which I'll show you in a case later. Next is the OSDI questionnaire. I know all of you have seen this questionnaire at some point. I'm sure a lot of you might even use this in your office. Hopefully you do. I love having this OSDI questionnaire. So what we do is we actually have this on a laminated sheet of paper. That way the patient can fill it out when they check in for their exam. What the technician does is that they just key it in to the software here while they're doing the dry eye workup. And what it does is it's actually going to give you a score at the bottom left that you can see there. So for this patient, the score is 23. The higher the score, the worse the symptoms. This is really, really important to do. This only takes about a minute, but this helps a lot with your patients to understanding their dry eye throughout the year or throughout your treatments. A lot of times patients don't remember how bad their eyes were at the beginning of treatment. It's kind of like when you change your patients into a new multifocal power and they're seeing awesome. And then they say, well, I feel like I saw better in my old ones, right? And then you have them switch back and they really don't see better in their old ones. So this is a good way to know, okay, this is today. This is what their score was, and this is how they were feeling. Because a lot of times patients feel like they're not getting better or they feel about the same, but really there's huge improvement. So I like to really just show them and quantify that for them. So the next thing that I like to show is this lipid layer. So I have two videos here side by side. The video that's on the left, you can see that there's almost like a mosaic of colors in there. So that's showing that there's a nice thick lipid layer within the tear film. So it almost looks like an oil spill on the straight. If you look at the video on the right, while it was playing, it looks like it just stopped. So while it was playing, all you could see was just the white light coming back from the keratograph, okay? This eye has a really thin lipid layer, so they're not having adequate lipid within their tear film. So a nice little visual for patients to look at as well. And then of course, the meibography. I really don't think you can treat dry eye without having meibography, okay? It's really like treating glaucoma without an OCT. Okay, and I'm sure there's a lot of people that are great dry eye doctors, but listen, once you invest in myopography, there's no way you'll feel like you can treat dry eye without it ever again. So this is a great way to actually visualize the glands in the upper and lower lids. Okay, so I like to show the patients this and show them actually what I'm talking about. I show them the atrophy that needs to be addressed. I show them this exact grading scale, which is built into the keratograph. And I say, I'll say, this is your glands right here. And a lot of times they say, okay, like, is it good? Is it bad? They don't really know what to compare it to. And then I pull up this grading scale. I say, well, this is 0. All the way on the left would be perfect glands. They're super healthy. You probably don't have any dry eye at all. Versus if you get all the way over to grade 3, you only got these little tiny nubs left. So I don't want to be treating your dry eye when you have little tiny nubs left here. We don't have a lot left to work with. So it really just buys in with the patient to say, wow, there's really is a problem and I don't want to get worse. Okay, because most of the time when the patients come in, unfortunately, they can get worse. So say they're at a grade 1 or between a grade 1 and grade 2, I might say this isn't terrible and your symptoms are not terrible right now, but it can get worse. And unfortunately, if you come to me when it's all the way at the end, there's not a lot for me to work with and not a lot for me to help improve your symptoms. So it's also a great way to capture those patients. Another thing that you can do as well, which I don't have a photo of, but you can also take photos and videos of the actual expression. So you can actually use the external camera on the keratograph if you want to, and you can actually show the expression, how clear those oils are, how thick those oils are. That way they can actually see, what kind of production that they're having as well. But I didn't include that today. But also another great thing you can do. So you're going to take everything that I just talked about and you're going to put it into a customizable report. Okay, so this is the Crystal Tear report. So this came out a few years ago, and it's wonderful. And it's great because you can customize it to your personal clinic or your personal practice. You can put your own logo on it. You can put all of their exact tear report. It has their name on it. It has, all their test scores. It talks about all the tests that you did. It talks about where they are. And then you can also just click in any kind of treatments that you have. Because let's face it, we're throwing a lot of information at our patients when they come in for these dry eye workups. I might be saying, use this specific artificial tear, do warm compresses for 10 to 15 minutes with massage. I want you on omega-3 fish oils. I want you to do a LipoFlow or an IPL, etc. And that's a lot of information for them to take in. And if I can have that written down, they can go home and relook at it again. And that just improves compliance to treatment. And I've actually had some patients bring back their reports the next year and say, I've been doing everything and this was really helpful. Dry eye can happen at all ages, but it tends to happen, the older that we get. So a lot of those patients are already on so many different medications. And if you can just lay it out for them, their compliance goes up tremendously. So this is wonderful. And then you can just print it off for the patient. And it gives them something tangible to take away from that office visit. So like I said, I'm doing this not at the routine exam. I'm doing this at a separate medical visit. So they're coming in another time. Typically this gets billed for their medical insurance, but if it does, like if they don't have medical insurance or if they haven't met their deductible, they're paying for your services. I want them to be able to take something home so that they can look at it, something tangible. It's great to put this into a folder, and then maybe you can put other brochures in there. So you're recommending specific treatments, specific supplements. You can put brochures in there as well, so that way they can read about what you're recommending too. So I'm going to change gears a little bit here. So now that I talked about kind of what I do for every patient that comes in for a dry eye workup, I'm going to talk more about specific interesting cases that I've had over the last few years where I've had to utilize the keratograph. And honestly, if I didn't have the keratograph, these patients would have been really difficult for me to treat. So the first one I'm going to talk about is a patient that came to see me because they just had reoccurring conjunctivitis, right? They just said, I have this pink eye that won't go away and I keep going to urgent care and they give me another antibiotic and then it comes back every 2 to 3 months, right? I'm sure we've seen patients like this all the time. it's dry eye, right? And they don't want to believe you. They don't want to believe you. There's no way it's dry eye. You know, they gave me those antibiotic drops and it got better, and I just keep getting these infections, right? So this was a patient that just kept coming back. But this one was a little different because this one was monocular, okay? So she always kept complaining about my left eye is red, my left eye is dry and irritated, it's inflamed. There's always injection on it all the time. But interesting enough, if you look at the right eye is pretty red too. But for her main complaint was always just the left eye. She made a lot of, you know, medical visit checks, little tiny 10-minute appointments just to address this left eye, okay? So she had been through everything. She had also done pulses of steroid courses, which of course made her feel better initially, just short term, but every single time it kept flaring back up again. So if you actually look at the redness score at her baseline here, you can see that it graded her redness for the right eye at about a 2.0, and the left eye was about a 2.7, okay? I just am showing you that just to show you how it really was asymmetric with her dry eye. And so I said, finally I convinced her, I said, you know what, I think this could be dry eye. I want to have you come back and do a full assessment. I don't want to keep doing these short appointments where I give you a prescription. So let's do a full assessment. Let's see what the heck is going on with this left eye. And it was really telling. So looking at the glands, the right eye looked great, you know, a little kind of twisty turvy with some of those glands there in the middle. But if you look at the left glands, so there's a whole chunk in there, about 3 or 4 glands right in the very center that are just completely atrophied or gone, okay? So I said, wow, there's your problem right there. It's always that left eye, and you're just missing a whole section of glands. What caused that? I don't know. You know what I mean? She's 58 years old. This could have happened at any point in her life. This was the first time we had done gland scans. You know, could it have been past trauma? Possibly. Maybe an old chalazion that never had healed and then got removed. A lot of times patients ask, you know, what caused it? We don't really know. You know, we haven't been doing this imaging for long enough to see, you know, 10 years down the road, 20 years down the road, what is causing all these changes, especially when it's just one focal area. So my instinct told me, you know, maybe she had some sort of, you know, major infection, injury, something where it obstructed those glands long enough that they just died off. Okay, so we started talking about treatment. Okay, clearly, just doing tears and just doing, you know, prescription drops was not working. So what I had recommended to her was actually doing LipiFlow because that's what we had in the office. So this was back in 2019. So there's many other treatments that are on the market that would treat the gland. So basically I just said, you're having a gland issue and we need to target these glands. So I knew that those glands weren't going to magically come back, okay? But I told her what the goal was that all the glands surrounding it, I want those to be working to maximum potential, okay? So I always joked, I said, the rest of these glands need to pick up the slack for these 3 that are just completely gone. And she would always laugh about that, you know, we need to get the rest of the glands going. But we talked about it, and, you know, the cost was, you know, expensive, okay? She was hesitant to try something out of pocket because she's like, well, how do I know it's going to fix my problem? Those glands are already gone. She was hesitant. So can I just try over the counters first? Sure. Great. So we did some warm compresses, we did tears, we did omega-3s. You know, we even added Restasis when those didn't work, but the flare-ups kept happening and she kept coming back to see me, okay? And finally, I just told her, I feel like you have to come back to see me so often. At this point, you could have just paid for a LipiFlow with all these office visits that you're charging to me. So we finally said, let's just try it, okay? And like I said, she was a little skeptical, but you know, sometimes you have to educate patients over and over and over again with dry eye until they finally jump on board. So she finally did it. So this is pictures actually. The left picture is her baseline picture, again, of that left eye. And the right picture on your screen is after the LipiFlow treatment, after her first LipiFlow treatment. So her redness improved from 3.2 to a 2.1. So her redness went down significantly just after the LipiFlow, just alone. And then looking at her tear breakup. So one of the great things about that tear breakup that we were talking about earlier is you can do these comparison maps. So it actually shows, you know, the progression to your patient. And I love these for follow-ups. So looking at where she started at, okay? So looking at the one on the left, you can see that she had really quick tear breakup. So about 5.5 seconds for the first breakup, about 8.5 average. But you can even see with just the map, the tears were not holding on the eye very long. And then as you move to the middle graph, this was after her first LipiFlow treatment. And look how much green there's there. Like the average breakup time improved a ton. She was definitely feeling significantly better after that treatment. And then she liked it so much that she actually came back and did it again less than a year later, because she can kind of feel, you know, my glands weren't working as good anymore. Let's do another treatment. So we did another treatment less than a year later. Your tear breakup went all the way up to a 15 and a 17. Like that's fantastic. And this was a woman that was suffering for years, you know, not figuring out what the problem was. So I was super happy with that, and I loved being able to just show her the difference there, right? And then looking at the glands. So like we mentioned before, we know that those glands aren't going to magically come back, right? But what I'm going to show you here is if you look at the picture on the right, which was her baseline, okay? You see that those glands that are atrophied. If you look at the picture on the left, you can see that those glands are actually like thicker and fuller, and they were producing more oil, okay? So the goal was to produce further dropout. We succeeded with that. When we looked at her OSDI score, it improved from a 50 to a 25. So that was another just telling thing with those symptoms. So again, importance of having the baseline, the tear breakup baseline, the OSDI, because they really just show the improvement that we had. So, and like I said, for this case, we use LipiFlow because that's what we had at the office at that time. It definitely, you can do this with anything else that you have. You can do this with iLux, you can do this with IPL, LLT, whatever your therapy is. It's great to just show before and afters. So let's touch a little bit more about my biography. So like I mentioned before, is this really the new standard of care with dry eye? And I think it is. And I have a lot of patients that agree with me, and a lot of patients that say, you know, why isn't every office offering this? You know, I've told doctors for 10 years that I had dry eye, and no one has ever showed me the glands or imaged the glands or talked about them. All they did was tell me more tears or drink more water or put me on a prescription. And I think the picture, you know, was really telling, and it tells us as optometrists, you know, what actually is going on, but it also shows your picture, your patients, what's happening too. So like we talked about, it helps with compliance, it helps with conversion with in-office treatments, you know, whether that be omega-3s that you have in office, or Bruder masks or LipiFlow, LLT, whatever it is, it's showing your patient, you know, the proof is right here of the condition that you have. It also helps to just show the severity of their dry eye too. So it's a good way to capture patients. A lot of times if they're asymptomatic, they might have severe gland loss, but that doesn't mean that they're not concerned about it. I've had a lot of patients that, you know, might not have the typical symptoms that you can think of for dry eye, but when I show them that they're having gland atrophy, especially if they're contact lens patients, and I say, you know what, this might jeopardize your future in contact lenses. Like they're like, oh no, I don't want that, right? And I don't blame them. I wear contact lenses, and I always joke, I want to wear contact lenses till the day I die. I want my patients to be super happy and comfortable in their contacts. So I show them this, and I say this could be a hurdle in the future that prohibits your contact lens wear, and they want to do something about it. So really great to visualize that for your patients. Accutane patients. So we all know Accutane patients have issues with dry eye, and this is a permanent chronic change. And this happens a lot in teenagers. So we don't really think about dry eye in teenagers like we should. But we've been using this a lot for pre-treatment photos. If we know that patients are going to go on it, sometimes you don't find out that patients are using Accutane until they're at their annual exam and already in the middle of treatments. But ideally, I'd love to get pre-treatment photos, mid and post, okay? And if you can start patients on, you know, omegas and warm compresses, or even doing like a LipiFlow in the middle of treatment, I've seen those patients really do well, you know, or even just doing warm compresses every day and educating them. It's hard to educate an 18-year-old to warm compresses, but they will if you tell them the importance of it. You can also grow your practice by talking to dermatologists about this. They don't know about this technology. If you go into a dermatologist's office and tell them what you can offer, I have a way to image the meibomian glands for your patients on Accutane and help it so that they don't get that chronic dry eye afterwards, they would be all about it. So if you could figure out a local dermatologist to work with to get referrals, that would be a great way to grow your practice too. Also just doing serial images. So even when my patients are happy, okay, we all want our dry eye patients to be happy, but once they're happy, I still at least like to do a workup every year just to make sure that we're not having further atrophy of the glands, we're not having a regression in their dry eye, so that I know everything that I was originally doing for their treatment, I don't have to add something, okay? And like I said before, I really feel like this is similar to OCT for glaucoma, okay? This is looking at the structure of the glands. This is looking at the structure, the main thing that can cause dry eye. So this is like a great peek behind the curtains of what actually is going on. So let's talk a little bit about compliance. So we all know people like to complain about dry eye, but then getting home and actually doing the treatment or doing the in-office treatments, that's another story, right? So you could prescribe everything that you want to prescribe for your patients, but I always joke with them, I can't go home and make sure you do all these things. Like, I'm not your mom, right? I need you to buy in and do the treatments as well. So what happens when your patients come back after 6 to 8 weeks and they just say, I did everything that you told me to, and I invested in this, and I'm not happy? What do you do? If you don't have baselines and all you have is that the patient says they're not happy, and maybe you do some staging and it's like, wow, I don't know, like I thought it was 1+ before, now it looks like 1+ SPK again. It's hard to really know if they're improving, okay? So having those OSDI scores before and after is really, really important. Having those tear breakup maps, having any fluorescein images that you have is great for saying, you know what, you're on the right track. A lot of times patients don't realize how far they've come in 6 to 8 weeks because they don't remember how bad it was. So I like to be able to show them, hey, listen, this was when I first saw you a couple months ago, and you really are doing better. You just got to keep going. A lot of times people want to jump ship after a week or two. If they don't feel better immediately, they're used to those antibiotics that, I put an antibiotic in and I felt better in 2 days. It's not going to go away in 2 days. Unfortunately, I wish it did. So that's why it's really important to schedule that 6 to 8 week check in just to make sure that they're doing better. And if they're not doing better, you need to change something. And I tell them that if you're not doing better, we're going to change something. It's just not an appointment just for me to say, give you a pat on the back or yell at you for not doing what you should. If I need to change something and pivot, I want to be able to do that at that appointment too. And the before and after fluorescein photos are really wonderful too. I have a couple great examples of that in a couple slides, just showing the SPK improvement. So think about your neurotrophic patients. A lot of times they always just feel the same, and they don't feel when their dry eye is getting worse necessarily unless you show them. This is good for amniotic membranes, if you're doing serum tears, if you're doing Regenerize, to just show that improvement on the eye in the picture. So here's another little case I'm going to show you here. This was a patient that insisted that her dry eye is not better. They invested in an in-office treatment, invested money in my office, and they're just still not happy. It was a patient that they came in for their follow-up, and I looked at their maps and I was like, wow, I was super happy with them before the technician even told me they're ready. And then, they walk in and they say, well, your patient's really mad and they're not happy and they're not better, and it's just kind of like, okay, what's going on? This is the reason why baselines are so important for education and compliance. Okay, so this was a patient that was 67-year-old Caucasian female, long history of dry eye from as long as she could remember. She had been using tears, warm compresses, omegas, ointment, had already tried Restasis, Xider, like she had tried everything, okay? So finally, we invested in a LipiFlow treatment, okay? And then she came back and she was doing better. And then at 6 months, she said, you know what, I don't think I saw any improvement at all. And, I'm not happy. I'm not happy because I invested in this treatment that you said would work and it didn't work. Okay, so let me just show you some photos. So this is her right eye. So the picture on the left was her baseline. okay, or before we did LipiFlow. So this was after already maximum therapies with everything else. And you could see that, you know, she has a reduced tear breakup. And then the one in the middle was actually right after her LipiFlow, or at that 6-month appointment where she said nothing, it didn't work. You know, I don't feel any better. But the patient had actually, you know, I thought visibly improved. It looked a lot better than before her treatment. So how do you get a patient that thinks that one in-office treatment did not work to invest in another one, right? I was thinking, oh my gosh, she's not going to want to do this, right? So we had just recently gotten an LLT, so the low-level light therapy, and we had been offering that to patients. And so I offered it to her, and I said, listen, you had a huge improvement with the one treatment I did of your glands, but let's try something different, you know? And this is another out-of-pocket treatment that insurance does not cover, but let's try it. And I showed her how, you know, you did invest before and it did improve you, but let's try to go even further. And it worked. So the third image there, she improved quite a bit. And then looking at her left eye, I mean, after that third LLT session, she was up to 20 seconds with her tear breakup time. Her OSDI score had improved to 6. You know, I'll jump back for a second. She had started at 25, which is not terrible, but it improved to a 6. You know, and a lot of times these patients just think, well, I'm still dry. Like I told her, you know, I don't think I can get you better than a 20-second tear breakup time and an OSDI score of 6 when you've had this your whole life, you know. So just showing them you are improving. And she actually left super happy and signed up for her next scheduled treatment, you know. So she went from saying, you know, almost like you scammed me, this didn't work, you know, this, and to saying, wow, this is really great. I'm going to tell everybody I'm going to sign up for my next one in 6 months. So having the keratograph just really converted that patient from being not so happy to super happy. So the last case report I'm going to show you is just something where we all see this, where we do a slit examination on our patient. And let's say they have a lot of SPK and they just insist, I don't have dry eye. My eyes are dry. I never use drops. I don't have a problem, right? So when people do this, I just take an image of it, okay? This is actually one of my colleagues' images, so I have to give her a shout out that she took these wonderful photos on the keratograph. So she said, okay, let's take a picture, and she showed her and said, look at these, all these here, those are like micro cracks in your hand. That's the way that I describe SPK. So I say if your skin is super dry, you get micro cracks in your skin, because I'm up in Michigan and it gets really cold in the winter, if you didn't know, and people get really dry skin. So they get that analogy. So I say your skin gets really dry. That is what's happening to your eye. Those are actually little micro cracks in your cornea, okay? So even though you don't feel this happening, it's there. And if this gets worse, this will start to affect your vision. You know, she was thinking about cataract surgery in the future. We want that ocular surface to be awesome, especially if they're doing a premium IOL. So faster healing, better visual outcome for the surgery, and just showing, hey, this is what it is. Your patients don't know what SPK is, okay? They're not gonna have any clue if you tell them you have 2+ or 3+ or whatever, but if you show them a picture, they understand that. So what we did was actually put her on Regenerize Light in office, and after just 3 weeks, you can see the before and after pictures that SPK had improved dramatically for that patient. So we did another picture, and we just showed her, you know, after doing this Regenerize therapy in office with the buying the bottles in office and taking them home, she did great. But it's hard when they feel the same, right? She didn't have symptoms before. How does she know that it's working? It's a nice way to show before and afters. And that could be with anything. That could be with amniotic membranes. This could be with serum tears. I've done this with Oxervate, Regenerize. So you name it, whatever it is, it's great for those asymptomatic patients to actually monitor their progression, or if they get worse, and sometimes they're not using their drops like they should. And you can say, hey, you're not getting any improvements. So in conclusion, I'm going to tie things up a little bit so we have time for a little bit of Q&A. We all know that dry eye is just growing at this tremendous rate, okay? I don't think it's going away. I think it's just going to get worse. You know, I wonder what the younger generation is, what that's going to hold for them. I wonder, are my daughters going to have dry eye when they're 20? So what's happening with that? But the main thing that I want to tell you is use that knowledge and use the tools that you have to capture those patients and set your office apart. I know some doctors that are actually just doing dry eye only practices. They're not even doing primary care anymore. So there really is a huge need for this in our space. And then just talking about the keratograph. So like I said, I'm going to talk to you about a topographer, and I'm not even talking about topography today, right? So we just talked about dry eye. So just looking at return on investment, okay? So with the keratograph, and like we said, we're not going to talk about any specific numbers or anything, but I did the ROI, and you could pay off a keratograph in a year if you just did 2 patients a month with any kind of in-office procedure that's out of pocket, like LipiFlow, LLT, IPL, or iLux. And if that isn't even enough, even if you don't do any of those treatments at all, if you just did like a level 3 in photos, like medical dry eye visits, you would only have to do 2 to 3 patients a week to have the keratograph paid off in a year. Okay, and that's just dry eye. So I'm not talking about how it does awesome maps for contact lens fittings, or looking at keratoconus or any other conditions. Like I'm not even looking at the topography part of it. I'm just looking at the dry eye assessment. And at this point, I've used it for so long that I don't really know, how I would do dry eye without it. So the return on investment is definitely there, especially if you're looking in the market for a new topographer, or you're starting a new practice and you don't know what to invest in. I think this is great. And then, like I said, this is just from firsthand. I've been using this for 6 years, and it's great. I love the customized reports that you can give for compliance, and it just really wows your patients that they get to leave with something tangible, and it has your logo on it. They get to take it home. So it helps make your patients, more compliant, happier with their dry eye. The return medical visits, when they come back to your office, when you do the assessment, it increases the traffic in there. It increases the traffic in your optical. More office visits coming in more frequently for their annual exams. Patient loyalty. So you got to think about the word of mouth referrals. You're offering something that nobody else around is doing. You're taking that extra step to image their glands and actually explain things to them. And that leads to a lot of great referrals from happy patients. And then lastly, just marketing yourself to outside providers. So, show them a mock-up dry eye report. Maybe go to an office that doesn't want to treat dry eye, or maybe in an office that doesn't do medical eye care. That's fine. Go to those offices and just say what you can provide. There's a lot of doctors out there saying they treat dry eye, but just say, look, I'm doing one step further. Like if you refer your patients to me, I'm going to take care of them. I'm going to look at the root of their problem, and I'm going to make them happy. So all in all, my advice to you is just do something that's going to actually help treat your patients, correctly. So use the diagnostic tools that we have now to make your dry eye patients happy. And all that is possible with the keratograph. So I've been super happy with it. So I'll go ahead and take any questions that anyone had for me at this time.
Perfect. Thank you so much for that presentation, Dr. Kuzner. I definitely have quite a number of questions ready for you.
Oh boy. All right, go easy on me.
Just a reminder for everyone, on your GoToWebinar screen, there is a text box if you want to ask any last-minute questions. And if you happen to miss part of tonight's webinar, or if there's anything you'd like to go back and review, you will receive a link to the recording within the next link, or within the next week. All right. So, first question. I'm just going to take care of this one really quick myself. Does the keratograph do axial length? No, it does not. All right.
But the myopia master does. So that's something different than Oculus can offer.
Absolutely. All right. So at the very beginning, you mentioned the Schreimer's test and how you don't really do it because it's invasive and it takes a lot of time. Instead, you do the Tear Meniscus height. Do you ever do the Fennel red thread test?
Nope. So I don't do that. Or I'm going to admit I have not done that since I was a student in school. I think those tests were great when that's all that we had. But now we have newer technology that I think is a little bit more repeatable, and I don't have to stick something in the patient's eye. I think as soon as you put something in that patient's eye, you're gonna get some sort of reflex tearing. Like even if you're using, you know, a drop to numb it or what have you, I just really like the non-invasive aspect of just taking that tear meniscus with them just sitting there without having anything touch their eye. I think that's more accurate with today's technology. So not knocking the old ways. I know that's the way we used to do it, but I think there's better ways to do it now.
Well, absolutely. It's always wonderful to see the advancements in technology. All right, I have two related questions, which are about how you review your exams. Do you review them at the Keratograph computer? Do you export it to an EHR system? Or do you have some sort of software set up in your exam lane that you review the exams at?
So the great part about the Keratograph is that it actually can communicate to any other computer that's on your network. So for me, we have laptops, and I can pull up the software as if I was on the as if I was at the topographer. I can pull it up in the exam lane and manipulate everything. So it's not just like a PDF. It's actually, I can look and click and pull up comparison maps live with the patient. So I do that on my laptop. And I typically will just write like a little summary in my EHR. The EHR I have is, you know, no EHR is perfect, right? So a lot of times I'll just kind of free text in there. You can always upload like a PDF into their file. I just personally like to free text in there so that way I can look back quickly. And I'll just put some pertinent information in my EHR that way.
Perfect. Thank you so much for that explanation. All right, next I have a set of questions about the breakup time, the non-invasive keratometric breakup time, the NICBUT. What do you do when the patient can't hold their eye open for even 5 seconds?
So I've had some that were less than 2 seconds, and it will measure it. If they can't hold it open for even 5 seconds, I mean, that's telling of itself. So I'll usually say, unfortunately, like you couldn't even keep your eye open long enough for it to record it because your eyes are so dry. So that's almost like instantaneous at that point. That doesn't happen often. Because I've seen tear breakups of like 2 seconds or so. So it can record them pretty quickly. Like if someone is blinking frequently, it's not going to give a recording. But then I'll just say, you know, I couldn't get a good measurement because your eyes are so dry. You can't even keep them open long enough to do the exam. And they acknowledge that. So.
Great. Do you ever take photos or videos of your meibomian gland expressions, or is that something you do with the slit lamp?
So that would be something you do if you want to do it on the Keratograph, you could do it in the Keratograph. So they have a great setting. I use this. You can do a video. I've done this for videos for like contact lens fittings, like gas perms. You can do a video of anything you want. So you can just have the patient in there, and then you can do the expression at the Keratograph. I think that's easier than trying to. I can never figure out how to hold up like my phone to the oculars. I'm not that talented. I feel like I could not express while holding up a phone to the oculars, or I don't have a camera set up on my slit lamp. So I just do it in the Keratograph. And like I said, I know we're not talking about contact lenses, but I use that video feature all the time with my gas perm labs. And I just put the fluorescein in there for the patient at the Keratograph itself. I'll take an image or video of like a gas perm lens, and I can send that right to my consultant. So you can take an image or video of anything on the eye.
That's awesome. It's nice to hear kind of those other applications on top of what you're already doing for dry eye. All right. This is a very important question to a lot of dry eye doctors. How do you minimize the no-shows for dry eye evaluations?
I feel like our no-show rate is not higher for dry eye workups than exams. We have not had an issue with dry eye workups being a high no-show rate, but I think a lot of that is because I'm educating them in the exam lane during their annual exam about what I'm doing. I'm not just saying, all right, I'll see you back for a dry eye workup and send them out the door. Then they're thinking like, what's going to happen? I give them like my 60-second elevator talk about what to expect at the exam and what they're going to get out of it and how we're going to move forward. So I rarely have people no-show unless like they actually have, you know, something going on in their life or they have to cancel. So I don't have that problem. You know, I think if you have that problem with any part of your practice, I've heard some people doing deposits. we personally don't, and we don't really have an issue with it.
Awesome. Okay, a few more questions about taking dry eye exams. How long does it take you to do one of your full evals when you're bringing someone back for a medical visit?
So I have my technicians do everything on the Keratograph. So they are trained, so they're doing all the data recording. That, depending on the technician, will probably should only take about like 10 minutes. And then I just go over everything in the room. So, you know, I tend to talk a lot, not surprising. So I tend to talk a lot. So I will spend maybe like 15 or 20 minutes with my patient just going over the results. You know, some patients are going to have a lot of questions and they're going to want to know, and some aren't. So it's different. The great thing is with your medical exams now, you can bill for time. So if you spend a lot of time with your patient face to face, bill for it. You know, that's just all I got to tell you. I mean, make sure you're billing the correct level based on your, how much time you're spending face to face with your patient. So I build that in, and I allow 30 minutes, I want to say. But, you know, I feel like those exams, if you think about how much we get paid for like an IMED exam, I think doing a leveled office visit with, you know, a therapy associated with it, you're actually going to profit higher if you use an exam slot for one of these workups.
That's good to hear. All right, next questions are about MyBiflow, IPL, and other such lid treatments. Which kind of treatments have you used? Which ones have you found kind of work best? And then the second part of the question is, do you kind of image in between treatment visits, or do you kind of do a before and after, like where you wait for all of the treatments to be done?
So it depends on what you're doing. Okay, so if you're doing a one-time treatment like LipiFlow, where it's just one and done for that session, I will do a treatment, and then I like to do a 6 to 8 week follow-up after that. If I'm doing something that takes 3 sessions, like an IPL or an LLT, I see them a month after their 3rd session. Okay, so it's kind of building on itself, and I always tell them, and I have the patient schedule all 3 or 4 or whatever your protocol is at your office. I have them schedule all of those at once, and I tell them I'm going to follow up with you about a month later to see how you did, because I don't want to do it like in between, you know, week 1 and 2. That's not really going to give me good data. As for what I've used in the office that I'm at currently, we have a LipiFlow and an LLT. So that's what we've been using mostly. I know we've toyed around with getting an IPL. I think that is a really great technology. So hopefully, you know, maybe adding that in the future. But I know the other therapies are really great also. It's just a matter of, you know, it's hard to buy everything, especially if you're in private practice. Maybe if you're in a school or a hospital-based clinic, that'd be great. So those are just personally what has been at the office I'm working at.
That makes a ton of sense. All right, we have time for 2 more questions tonight. We're getting about to the hour. I'll try not to go over. The second to last question, or penultimate question, is about mybography, and how much harder is it to get a superior mybography over just the inferior mybography, which you said you use just the inferior mybography as your screening.
So I mean, obviously inferiors are going to be easier because you don't have to flip the lid. That's why we do it during the routine exams, because people are not going to object to that at all because it's just so non-invasive. The uppers are a little bit more challenging. I know all of us had to learn how to do it in school. All of us had to learn on each other. We know that some of our classmates had tougher lids than others. So it's a little bit harder, but I think with repetition, like all of our technicians know how to do it, and they learned, and we taught them how to do it. And you know, if they experience a difficult patient, then they can ask one another, ask myself. But I rarely have an issue with them not being able to flip an eyelid. So I would say a little bit harder, but we've been able to train all of our technicians that didn't come in with any other, you know, optical or eye experience. They just kind of came in from, you know, brand new to the eye world, and they were all able to learn how to do it like in a day. So I don't think it's impossible for technicians to learn at all.
Mm-hmm. That is one consistent thing that I run into. I speak with a lot of doctors and a lot of technicians, even though I'm not a doctor myself. Just give your staff the time to get familiar with all of these capture techniques on any of these exams, whether it be with the Keratograph or any other device. They need that time to learn how to take a good scan. All right, and time for the final question of the night. You mentioned something I found really interesting, which were patients currently taking Accutane. What do you look for specifically when managing those Accutane patients?
So like I said, ideally I'd love to get baselines before they start. Unfortunately, that's not usually what happens. I like to look at expression because sometimes I'll see the glands are intact, but the oils are not expressing at all. So if I look at expression and I push and push and push and nothing is coming out, that's a problem. That's a sign that those glands are going to atrophy. Like I know they're going to. Sometimes I could look at the glands and they almost look like they're empty a little bit or getting skinnier. So they're not, they're not dead, they're not gone, but the oil in it is definitely not as full. So I look at that as well. But a lot of it is just doing the expression and just having the nice baselines to go by. And hopefully I hate seeing the before and after, if I saw them 1 year and then 3 years later they come back in and it's worse, then, it's hard. But a lot of it's the expression and then looking at the tear breakup time as well, looking at those maps.
Absolutely. All right. Well, thank you so much for all of your incredible knowledge tonight. Unfortunately, that is all the time we have. But thank you for everyone who sent in questions. Thank you for joining us. And thank you so much, Dr. Kuzner.
All right. Thanks to all of you for giving me an hour of your time in the middle of the week.
Good night, everyone.
Good night.